We'll move on to our last segment of this particular section, just a complete different concept, endocarditis with IV drug use. We need to talk about it. So let's talk about it, Dr. Yoon.
Well, it's called maximally invasive heart surgery. Okay, next slide. Oh, am I pushing through with this? Okay. So no disclosure. So at UPMC Presbyterian, we have a multidisciplinary endocarditis team, and these are the team members. And sometimes we get even more subspecialties involved. So since the start, we've had 258 valvular endocarditis patients evaluated, and this excludes the lead infections. And out of those are the numbers of procedures that we have performed. So we're going to talk about the good, the bad, the ugly of the endocarditis and IV drug use patient population. So the change in etiology of endocarditis is the main thing is that over the last couple of decades, the IV drug use patients have become really the big portion of this patient population. And these patients have 100-fold increase in risk of endocarditis. So to discuss the good and bad and ugly, I'm going to give you some case reports. Here is a first case, HD, 30-year-old female. She had aortic valve replacement and other complex procedure done in 2015. And she actually stayed sober for a decade and compliant with all the methadone clinic and such. And she returns with severe prostatic aortic valve stenosis. And upon request, she quit drinking right away and, really compliant. And then we end up doing her surgery, redo AVR on March 28th and was discharged home on April 2nd, really 5 days. So really a good outcome. But so what is bad about it? Well, the morning of surgery, this patient, somebody called our OR front desk and saying this patient is drunk and doing all kinds of drugs the night before surgery. So, we're thinking about canceling this patient's case. Well, it turns out it was her mother, who's a drug addict, decided because she had an argument previous night that she decided to sabotage this patient's surgery. So it really shows the social aspect of a lot of this patient population. They really have frequently very unstable social situation, and that becomes a big problem in managing these patients. And this is the, really just structural deterioration of the tissue valve after 8 years, and she got a nice mechanical valve. The other case, polysubstance abuse, IV drug use, ETOH. He also had a lot of other issues, HCV, cirrhosis, pancreatitis, Crohn's disease, status post ileocystectomy. He was admitted with left thalamic stroke and right parietal subarachnoid hemorrhage, sorry, not hemorrhoid. So patient had renal splenic infarct, MSS endocarditis. During the hospital admission, patient ended up having a ruptured spleen, and he required splenectomy and also had event of hypovolemic shock with PEA arrest. Patient also required other procedures such as embolization. How do I play this? So this is the aortic root abscess, and in fact, actually, the abscess really looks like outside the aortic valve, ascending aorta. He underwent resection of infected bicuspid aortic valve with vasectomy and debridement of aortic root abscess, exclusion of the aortic root pseudoaneurysm, aortic root replacement with a homograft, and drained ascitic fluid, pericardial effusion, and pleural effusion. At the time of surgery, EF was 20%. If you look at this slide, the patient was in the hospital literally from July 2020 till April of 2021. So you're talking about really 8-9 months of hospitalization. And the operation itself was a pretty ugly procedure. But the good news is that patient's EF improved from 10 to 15%. So after several months of management by the heart failure team, EF improved to 55 to 60%. And this patient's been drug-free for the last 2 years. It's an ugly case, but good outcome. Now, This patient has lived with his mother for the last 2.5 years, and that's been really, the family support's been very important. He's actually going to be leaving his home to become independent. Now, how well he's going to do, we hope that he will continue to do well. These are some of the tissue that we pulled out, and the patient had a homograft, and this is the procedure he's had. This is another case. The patient was admitted at Mercy May 19th with shortness of breath, malaise, progressing to septic shock. MLSA bacteremia, tricuspid valve endocarditis with septic pulmonary emboli, complicated by respiratory failure requiring mechanical ventilation and acute renal failure. Patient was transferred to Presby and underwent tricuspid valve replacement with tissue valve, and patient did well. Preoperatively, we have multidisciplinary team approach with involvement of addiction medicine, and really, we try to set up this social situation as best as possible. Unfortunately, we last spoke to her on August 24th, and she reported things were going well, and she was being very compliant. August 26th, she died of a fatal overdose. And this is a sample of a lung CT on the left side, and let me see. And that's the tricuspid large vegetation. And this is some of the tissues we pulled out, and she ended up getting a tissue valve. The problem with this patient population is recidivism, and frequently we are faced with, second and third, fourth, operations. And if you look at these patients' outcomes, every time we go back for redo, their morbidity, mortality, skyrockets. And if you look at really the big picture, these patients die from really the recidivism, not surgery. So drug addiction is the primary pathology, and the endocarditis, these are basically their symptoms. And we know that it is the inpatient cardiac rehab is, very cost effective, but, availability for amount of problem we have is just minuscule. So, we face an ethical dilemma. As we saw in one of those patients, the patient was in the hospital for 8 or 9 months. So, is society able to, pay for that? How do you allocate resources? And also, when does recidivism confer utility? We had a patient, as patient was leaving the hospital, was injecting. So, is that futile? And also, while patient autonomy and safety is highly valued, what about safety and autonomy of the surgeons and teams? We have patients, really, cursing out the nurses, calling all kinds of names. How do you deal with that? But some feel that how is this different than, the CABG patients that we treat after discharge within a few months go back to smoking. And, the morbidly obese patient, after we do the procedures for morbid obesity, they frequently do go back becoming morbidly obese again because they've failed procedure, not because of the surgery, but because of, really the lifestyle. So, one would ask, how is this different than, those? But, that's food for thought. But this is certainly a difficult patient population. I think UPMC Presbyterian is probably in endocarditis. As far as endocarditis is concerned, we do cover Western Pennsylvania, Maryland, and West Virginia because we get patients from all of these areas. These are not patients that I think other hospitals are very freely and willingly to send to Presbyterian University Hospital. With that, finish my talk. Thank you.